On behalf of the Obstetric and Gynecological Society of Southern India, like to welcome all the faculty and the delegates for the session on Clinical Skills Hour, CTG, Labor Care Guide and Partogram. We have our President Sampath Kumari Madam, myself Secretary Dr. Meena and Meenakshi Sundaram Treasurer, and our dear moderators Jayashree Gajraj Madam and Dr. Deepa Tangamani Ma'am, who will be moderating the session. And we have our panelists, Dr. Anita from Vijaya Hospital, Dr. Apurva from Railways Hospital, Dr. Sakshi from Meenakshi Medical College. So I take this opportunity to welcome all the dear faculties and the delegates for this session. Over to you, Dr. Deepa Madam, to take over the session.
Thank you, Meena. Thank you so much. May I ask Dr. Triveni to be muted. Dr. Triveni, please mute yourself. Yeah, thank you. So we'll start. So today's program is like we are mainly concentrating today only the CTG. It's just like a revision class. So whether we are going in the right directions, whether our basics of interpretation is correct, how to identify any hypoxia in CTG, and practical some tips and do's and don'ts in CTG interpretations and the new terminology. This is what we have today. So we are not discussing LCG today. Mainly today is a topic for CTG. We have 3 young people to discuss the traces in the Dr. C. Bravada format. So first initially some basic, then traces, then hypoxia evaluation, and then another some traces. So this is the agenda for today. So I'll invite Dr. Anita, Apurva and Shakshi. Okay, so both are well prepared. I hope so. Okay, so don't worry, it's just a basics. Okay. Sorry. Okay, so we all know. So whenever you plan CTGs, you have to familiar with the machines which you are using for a longer times in your institute. So the machine has to be set up, this paper speed 1 centimeter per minute. I keep on telling them how the papers 1 centimeter per minute will looks like, and the paper speed of 3 centimeter per minute is looks like. So the 1 centimeter will be looking like properly. The 3 centimeters is very fast and it will be more stretched, and we cannot interpret. What we see as a normal variability will be decreased variability in 3 centimeter per minute. So the dictum is the paper speed should be set at 1 centimeter per minute. So whenever you go back, see the machine, see the paper, familiarize with the paper, familiarize with the machine, and make sure it is set at 1 centimeter. Next important step in the CTG is the date and time are correct. Okay, so CTG paper, whatever the date mentioned in the CTG paper should be correct exactly as the date and time of the wall clock, labor wall clock. Okay, both has to be very similar. Fine. Okay. Next, the date and checking of the machines has been validated. So it has to be like every duty, every handover that has to be validated. And labor CTGs, once the 20 minutes stage is finished, or do not interpret a 3-minute stage or 4 minutes or 10 minutes trace. It's always at a minimum of 20 minutes, and actually 40 minutes is an ideal trace to interpret. Okay. Why not that 5 minutes? Because 5 minutes we cannot interpret. There is no point of telling what is baseline, what is decelerations. We have to integrate all four parameters and give a conclusion whether the CTG is normal or not. So 20 minutes is necessary. But whenever there is a prolonged deceleration, then immediately you have to alert the team. So what is that? So as soon as you put a CTG, there is a prolonged decelerations. There is a deep decelerations, or the maternal heart, the baby heartbeat is like 100, 80, 90. For it lasting more than 22 minutes, then you have to alert the whole team. So that is when you have You have to be worried that time. Okay. So then adequate papers. There will be a paper will give you the clue. So when the paper is getting over, you will see there is a there is a red color. There is another 3 minutes paper or 4 minutes paper or 10 minutes paper only it is available. So that gives us a clue that there is not an adequate paper. So when you need a 20 minutes trace, then you have to redo the paper. One second. How long the CTG paper has to be stored? The traces has to be stored digitally for 25 years. So suppose if there is a problem, if the baby is not crying, if the upcar is very less, or if you have the baby stayed in NICU for longer time, that baby's CTG traces has to be stored indefinitely. That means lifelong. When as long as the baby is alive, we have to indefinitely store the traces. So, what are the 4 futures we will be doing it? Apurva, what are the 4 futures or 5 futures rather you will see in the TTG trace? One is contractions, then only the baseline. You remember always Dr. C. Bravado. So, define risk, then start with contraction, then baseline heart rate, then variability, then acceleration and decelerations. So, these are the 4 parameters. In the accelerations, in the variability, I have mentioned few others to be seen. That is called cyclicity, is whether the pattern is sinusoidal or it's a saltatory or zigzag pattern. This is also very much important. Okay, so once you categorize baseline, variability, acceleration, deceleration, you have to categorize each into whether it is normal or it is an amber or it is red, which we will discuss little bit later. Then once all the categories has been done, then we have to tell them that it's a normal CTGs where the baby is needed a normal care or suspicious CTGs or pathological CTGs. So normal fetus or hypoxic fetus. This is the one thing you will be doing it. So either you follow the Dr. C. Bravado and follow this sticker as a guideline for the Dr. C. Bravado. So this has to be stick on to your labor ward unit. Okay, this has been taken from the NICE guideline. When you mention contractions, if the contraction is less than 5, it is comes under white. White. If the contraction is 5 or more contractions or less rest in between the contraction or hypertonus, it is comes under amber. There is no red in the contraction part. Then come the baseline heart rate. Baseline, whenever the baseline heart rate is mentioned, you have to write the original baseline heart rate. What does it mean, the original heart rate? So if the baseline heart rate is 110 or 120 or 130, you have to mention that 130 or 110. Why? If the, even 110 is normal, 160 is normal. But suppose if the patient comes in the labor and the active phase 5 centimeter, if the baseline heart rate is 120, and after some times like in the second stage the baseline heart rate is 150, then there is a rise in baseline. That is an abnormal thing. So that is the purpose of writing the baseline's original heart rate. So if it is a 110, you have to mention 110. Okay, so whenever the baseline heart rate is mentioned, you have to write the baseline. Also, there is a baseline heart rate has to be appropriate by gestational age. So unstable baseline. These are the two things has to be mentioned. Stable baseline means baseline. Whenever the baby is having acceleration or deceleration, coming back to the baseline, that is called stable baseline. Appropriate for gestational age. Why it is appropriate for gestational age? Suppose if there is a preterm babies. So preterm babies, what happen in preterm? The parasympathetic and sympathetic develop little later. Parasympathetic maturity will develop little later. That means as the gestational age advances, the baby will have a good parasympathetic. So the baseline heart rate, which is very high in the preterm babies, will come to stable. So when you see the babies in the term like 37, 38, 39, 40 weeks, then the baseline heart rate which we expected to be is like 120, 110, 120, 130 or maximum 140. If the baseline heart rate is 150 when you see a 40 weeker, then it is not an appropriate. That baby has to come into the some kind of scrutiny or some kind of surveillance is needed for that baby. Okay. Stable baseline means whenever there is a deceleration, even the baby comes to the stable baseline, staying there in the baseline for more than 2 minutes, then it is a stable baseline. So that is all normal. Then what is amber in baseline? Suppose, as I said, from the original baseline rate, if the next strip, next 1 hour strip is 140, 130 beats per minute, there is increase in 20 beats from the start or last review 1 hour, then it is an amber. That means suspicious CTG. If the baseline is 100 to 109, that is also amber color. Suppose if the baseline is unable to determine, then it is also amber color. What is a red in baseline? Red is an abnormal. So anything less than 100 bradycardia, more than 160 tachycardia, or increases of 20 beats in the active second stage of labor. So any heartbeat, like suppose 140 beats and it goes into 20 beats in active second stage of labor, that is an abnormal red alarm. So this is what baseline. Then comes to the variability. Variability in the normal is 5 to 25, less than 5. Staying there for 30 to 50 minutes is amber. Variability, increased variability for even 10 minutes is normal. It's amber. So less than 5 beats or more than 10, 50 minutes and more than 25 minutes, 25 beats for saltatory pattern for 10 minutes is red color. Deceleration. Decelerations, these are the deceleration or white color, which means they are normal. No deceleration, all early deceleration, variable deceleration with no concerning features comes into the white color. That means they are all normal. So when you see the deceleration, so you normally basically do not alarm with any decelerations. Deceleration is the way the baby is responding to the stress. So when an adult running, jogging, when they have a stress, increase load happens, they increase the pulse rate as well as they increase the respiratory rate. So that is the way the
கொஞ்சம் ஜாயின் பண்ணணும்னு மெசேஜ் வந்திருக்கு. இது
that
இது
is
வெபினார் கிளாஸ் மாதிரி நடக்கும்.
that excuse me, that is the reason that is so deceleration is a one way. So I request everyone, please mute it, ma'am. Okay, Chitra, please mute yourself. Yeah.
7 மணி வரைக்கும் தூங்க வைக்கிறாங்க. அததான்
Okay. Okay. So variable any deceleration, see whenever you see the deceleration, don't get alarms. Make sure it is a variable deceleration with a concerning feature or late deceleration. Otherwise, deceleration is the way the baby is reducing the myocardial effort, thereby increasing its reserve. So that is the reason. The baby can't breathe like an adult responds to the increasing the oxygenation. How the baby increase oxygenation? By decelerating. So decelerating, it catch up its oxygenations. So what the repetitive variable deceleration with concerning features less than 30 minutes is an amber, and variable deceleration concerning features more than 30 minutes is with no repetition is an amber. Repetitive means like coming again and again, each and every contraction it's having a late deceleration, a variable deceleration, that is a repetitive. So any repetitive deceleration which passes more than 30 minutes, then it is a red color, or acute prolonged bradycardia is a red color. So CTG at the end of the, we have either it could be suspicious or pathologicals. That is how you have to write in the overall impressions. And you have to put a signature. And at the end of this, whether his baby is having any hypoxia or not also you have to mention. So what normally we'll see is a gradually developing hypoxia, which is the hypoxia which most likely we will be missed. Okay. So this is of the 3 centimeters on 1 centimeter paper. So 1 centimeter, that's the standard speeds where you will be seeing the variabilities. The 1 centimeter per minute means you will be using for 3 centimeter 3 minutes, you will be using more papers. Like 9 centimeter paper is waste. So your variability will be stretched. Only problem is variability will be stretched. And you can't see the acceleration. You can see only acceleration properly in 1 centimeter if the speed set at 1 centimeter per minute. We'll go with one by one. So whichever we discussed are here. So when you see the contraction, 3 things you have to see. One is number of contractions. Number of contractions. Then is there any rest period between the contractions? Is there any rest period between the contractions? Rest period means it should be more than 90 seconds or 2 large squares, like 1-2 minutes if the baby has to rest. So at least minimum 90 seconds. The same thing reflect for the baby also. Baseline also. Baseline has to come to the baseline resting period or stable for 2 minutes. Okay. So this is the baseline resting period. This is a baseline resting period. But here there is no resting period between the contraction. That is more number. So any contraction more than 5 contraction, or if the contraction associated with the decelerations, it's called hyperstimulations, and this is called tone. So what is the duration of the contraction, which we normally see is like the duration is this one from the beginning to the end. That is the durations. If it is one big square, it is called 60 seconds. So normally the duration is like 30 seconds, 40 seconds or 60 seconds. This is what we will be meaning. The amount it's going up and staying there, it's a tonic contractions. That is what it was mentioned here. So all these things you have to, subtle things you have to see in the contractions. Okay. So baseline appropriate for gestational. These are all the things we discussed. So what is this? So baseline, where do you see the baseline? The baseline has to be seen between the two large squares. Okay, two large squares. So minimum you need a 2 minutes to discuss the baseline. So we can't see the baseline here. This is because it's only a one large squares. We can't see the baseline here because there is no resting period. So only this or this. So at the end of the trace, you will be seeing. And when you see the baseline, there should be no contractions. There shouldn't be any, in between the contraction, in between the two contractions only, you have to see the baseline. Or in between two accelerations, or in between two decelerations. Okay. So when you cannot see the baseline for the last 2 minutes, here in this trace, there is no 2 minutes where we can see the baseline. So what do you call this? Indeterminate. So this baseline is indeterminate. What do you do now? We have to see the previous CTG to look for the baseline heartbeat. So this is, if this is the first CTG, then you cannot stop at 20 minutes or 40 minutes. You have to continue the trace till you see this kind of baseline CTG. Fine. Okay, this come under the amber. So this is come under the amber color. Amber means it's a suspicious CTGs. Okay, so this is comes under baseline unable to determine. Yeah. So come to this. What is this? Where do you see the baseline? So as I say, baseline has to be seen in between the contraction. So this is where you can't see anywhere. Either why not this place? Because this place there is a contraction is there. So I can't see this. So in between the contractions where the baseline is there, I can see the baseline heart rate. So not though there is more than 2 minutes, but there is a fleeting contractions is happening, like duration almost like 15 seconds. So I can't see the baseline here. Fine. Okay. So this is the place where you have an adequate rest in between two contraction, in between two decelerations. We will be seeing the baseline. Where do you see the baseline? What is the baseline? Here the baseline something around 90 beats. So is it normal or not? Can someone answer? 90 beats is normal? Can someone answer? Is this baseline is normal? What are you seeing it here?
No, ma'am. No, ma'am.
Ah, okay. It's normal. So when you see 90 beats, what your mind thinks about? It's a bradycardia, or what do you think about?
Fetal bradycardia.
Fetal bradycardia. So any other suspicion will comes to you. This you have to see the mother's heartbeat. Okay. So you have to confirm whether it is a fetal heartbeat or maternal heartbeat. Check with a Doppler or check with an ultrasonogram. Confirm this is a fetal heartbeat. Okay. Fine. Okay. So what is this? What is the heartbeat here? So where do you see the heartbeat in between two contraction or in between two decelerations? And you have 2 minutes. This is the baseline heart rate. So what is the heart rate here?
Ma'am, It is 160.
Ah,
Baseline heart rate is 160, ma'am.
160. Is it? It's a for 39 weeker. Suppose he's a 39 weeker. Is it normal or not?
ரிவிஷன் பண்ண எடுத்தா தானே எனக்கு இது வேணாம். நான் ஏற்கனவே ஏகப்பட்ட சாப்பிட்டேன்.
Hello, doctors. Please mute yourself. Okay, Anita.
Yes, ma'am.
Is this a baseline is appropriate for gestational age?
Yes, ma'am.
Okay, so is it, she is a 39 weeker, priming, gone into the labor, the heartbeat is 160. You have seen the baseline heart rate in between the two contractions. Is it normal? Is it appropriate?
Maternal pulse rate.
No, it's not maternal pulse. It's a maternal. Okay, okay. So what are you seeing it here? Is a decelerations. Okay. Okay, so in between contractions, what I was teaching you now is like baseline heart rate between 110 to 160 is normal.
It's normal. Yes,
Whenever
ma'am.
you put a heartbeat, whenever you see the heartbeat, you here you are going to mention it's a 160. Okay,
Yes, ma'am.
160. Do you expect this 160 baseline heart rate in a 40 weeker?
No, ma'am.
No,
So
ma'am.
160 is for a 40 weeker is a baseline tachycardia. So it comes under amber. That is, it is suspicious. On top of it, there is a fleeting deceleration. It's a quick decelerations. Okay. So this baby's CTGs, you have to see the previous CTGs, previous 1 hour or 3 or 2 hours before CTG, you have to see.
Yes,
Okay.
ma'am.
Okay, so if from the CTG, if there is an increase in baseline heart rate of 20 beats per minute, then this is baby is going in for compensated tachycardia. That means
Yes,
hypoxia is going, baby is compensating that hypoxia by increasing the adrenergic drive, catecholamine drives. So whenever the baby is hypoxia, the first thing baby is trying to do is to make it normal. So her baby's adrenal gland try to work. So steroid hormones will come. So when there is a steroid is coming, adrenaline is coming, that heartbeat is increasing. Thereby, try to maintain the oxygenation. That is a compensative form. Still, the baby is fine, but baby is compensating. Anytime the baby will go for decompensating. We don't know. Okay, so this is we need to reassess whether we make sure whether this is correctable. Do a PV, assess whether she is in labor. If she is not in labor, try to correct, do an intrauterine resuscitations, and then follow the trace, make sure, evaluate whether it is correcting. All those things you have to do it. Okay. So by looking at a baseline itself, you come to conclusion, this is for a 40 weeker, this is not a normal. Okay.
yes, ma'am.
Okay. So this is a red, I put as a red color. Okay. So coming to this trace, will you able to see anyone have able to see the baseline here?
No, ma'am.
No,
See,
ma'am.
priming 40 weeker, active labor 8 centimeters, clear like a draining. Dr. C. Bravado, there is contractions is there initially. After that, maybe we have to check it whether the toco is placed correctly or not. But seeing the baseline, do you have the stable baseline?
No, ma'am.
So whenever you have a baseline, we have to see the baseline is in single line, single denominator, you have to see the baseline. Okay. So, and you need a, as a 40 weeker, we are expecting something around 110, 120, 130, 140, not more than that. Okay. That is second dictum. That is baseline appropriate for gestational age. So here, but we need a two big squares, that is 2 minutes trace, and in between the contractions. So in between the contraction, here the baseline heart rate is 160. In between the contraction, here the baseline heart rate is 140. And rest of the times you couldn't able to see any 2 minutes trace, correct?
Yes, ma'am.
Yes,
Okay,
ma'am.
so what is happening?
Increase in baseline 20.
Increasing the baseline heart rate. Okay. You forget about all the decelerations. Just see only the baseline. Okay. Just see the baseline. The baseline is not stable. Somewhere it's 140, somewhere is 120, somewhere is 160. Okay.
Yes,
somewhere is 160. So towards the end, this is actually going in for terminal bradycardia. So this is an unstable. So when
indeterminate.
you say the baseline heart rate is absolutely normal, you should be between 110 to 160, and it should be appropriate for gestation weight, and it should be stable baseline. So here it's not coming into any of the criteria. So either it's an amber or red color. Okay, it's a very abnormal baseline. So with seeing this baseline itself, you can see this baby is hypoxic. Understand?
Yes,
Yes,
We
ma'am.
are still in the baseline and we understand that this baby is hypoxic. The reason is the reason
increase
is
increase in beats.
increase in the baseline heart rate. Okay. And it is not stable. Only one, two places I can in the 40 minutes days, I couldn't able to see the stable baseline. Stable baseline means we cannot able to see the 2 minutes trace. That means baby doesn't have a rest period to get the oxygenation back. Okay. So babies spending more time in deceleration. All this mark is decelerations. Okay, all this mark is decelerations. Baby spending more time in decelerations, not able to come to the resting period to get it oxygenations. Okay, fine. So we'll move on to the next parameters. So keep changing is unstables. Next is a variability. Whenever you see the variability, you have to, what is variability? It's a 5 bits. In a 1 minute, that is 1 week squares, how many bits is going up and down? Okay. So in a 1 minute, so this one big squares, this 120, this is 125, 135, 140. Okay. So in a 1 minute is like 10 beats. Okay. So one beats, how many beats it's going up and down? So the upward and then coming down. This is called heartbeat up and down. 5 beats above, 5 beats below. That is called variability. So here 5 beats above, 5 beats below. So it is adequate normal. This is how the baseline variability has to be checked. Whenever you see the variability also, the same place where you check the baseline heart rate, you have to check it. Okay. If the baseline variability is less than 5, it is a less variability. Saltate, if it is more than 25, it is a saltatory. Then what is sinusoidal, what is zigzag, and what is cyclicity? Anyone knows cyclicity? What is cyclicity? Okay, I'll teach you. So whenever you tell, you have to tell whether the variability is, what is the variability? It's 8 beats, 5 beats, or 10 beats, and whether the cyclicity is present. Cyclicity means the baby will have a sleep-wake cycle. Some of the period in the 40 minutes trace, the baby's variability will be less than 5 beats. That means that is also normal. That sleep-wake cycles cannot go beyond 20 minutes or 25 minutes, maximum 30 minutes. And after that, the baby start more active. Fine. The cyclicity waves, the sleep patterns will be absent. The baby is hypoxia. So how baby, we cannot sleep whenever the baby doesn't get an oxygenation, baby will be more awake and want to compensate for this. So that is a reason the cyclicity is blunting. That's because that autonomic nervous system is the cyclicity is the variability is basically because of the fluctuation between the sympathetic and parasympathetic. So if it is blunted, then cyclicity will be absent. Also in hypoxic fetus, will try to be more awake and more and there won't be any sleep cycles. So that is the two reasons. We can say the cyclicity is absent. So if you see the cyclicity and you have to see the baby is sleep wake cycles is normal. Sinusoidal is like a waveform. Zigzag is like a chuck chuck chuck. I'll just show the trace. We have to tell whenever you describe the variability, do not say beat to beat variability. This beat to beat, the going up and down, it is cannot be seen in the naked eye properly. Okay, it is a computerized CTG only, we can say beat to beat variability. So here the beat to beat abundant terminologies, short term, long term variability, short term variability. We cannot say in the normal CTG paper we are seeing, only in a computerized papers we can see that. Okay, so what is this CTG's paper says? What is the variability? Just concentrate only on the variability. Do not concentrate on the contractions or baseline. So what do you know about this? Baseline here, it's like 150 beats per minute.
Variability 3 beats to 3 beats.
So 3 beats and less than 5 beats. So 3 beats is less than 5 beats. It is saying that this is 9 minutes, 18 minutes and almost 30 minutes same, 27 minutes. It is 27 minutes same, 30 minutes less than 5 beats.
Yes, ma'am.
Okay. So what do you do? What do you call this variability? Do you worry? Is it a sleep pattern?
Yes, ma'am.
It is a sleep pattern.
Ma'am, up to 30 minutes, we can say it is a sleep pattern.
So what do you do? Continue the CTGs. The second
Yes, ma'am.
CTG is we have continued the CTGs. Now, do you call this again a sleep pattern?
No, ma'am.
So what do you call now? It's a reduced
Reduced
variability.
variability.
So reduced variability. How long the reduced variability can be there?
50 minutes.
Up to 50 minutes. It's a amber. More than
Amber.
50 minutes.
Red.
Red. So if you combine these two things, it's almost 12 o'clock. It started. It ended in 12:50. So more than 50 minutes. It comes under red color. Okay. This is the first CTG which started at 12 o'clock. Which started at 12 o'clock. Here the time is mentioned. It is ended at 12:50. Okay. So this is red color. If it continues like this, it's red color. So when your admission CTG is like this, okay, then do reassess antenatal surveillance as well as do an intrapartum surveillance. Intrapartum assess the PV, assess the progress, whether she is in labor or not. Even if she is in labor, this baby will be fit to go into the labor. We have to assess. This baby is having already exhausted all the reserve. So when you have the contractions, it doesn't have any reserve to make it abnormal to go through the labor. Okay, so this comes under the category of chronic hypoxia because the baseline variability itself is less than 5 beats, which stays more than 50 minutes. Okay, suppose I say this is a 40 weeker. The baseline heart rate of 150 beats per minute and less variability. Okay, so what do you suggest?
First, resuscitate, ma'am.
Resuscitate. Okay.
Left lateral position. Then continue the CTG for again 40 minutes, ma'am. Followed by PV examination.
Good.
And then
Very
after
Very good. Okay. So the dictum is when there is a less variability, if it is even after resuscitation for more than 40 minutes, then we have to worry. And also there is some clues we can get it. If a 40 weeker baseline heart rate is 150 beats per minute or going into 60 beats per minute and less variability, that means cannot be a sleep cycles. Okay. None of us can sleep with a heartbeat with high position. So with even an adult can't sleep whenever our sleeping pulse rate will be very normal. Never been a tachycardia. So the same thing for the baby also. 40 weeker, I cannot expect 150 beats as a normal. So I'm expecting something around 110, 120 only for the 40 weeker. With this 150 beats, the baby can't sleep. Okay, so those are the subtle clues we can get it from the CTGs. So baby can't sleep as a tachycardia. So when there is a fetal tachycardia, the cyclicity won't be there. The baby can't be sleep. The variability should not be less. If the variability is less and tachycardia is there, then that is a concern. If it is persists for the longer time, the baby cannot cope up the labor. Fine. So with this, we'll move on to the cyclicity. This is what I am mentioning the cyclicity. Okay, the same CTGs, this is less than 5 beats and towards the end it's more than 10 beats. So, okay, here also list is 5 beats, towards the end it's more than 8 beats. So both the CTGs are normal. This is an active sleep-wake cycle. Okay, so someone tell me, Anita or Shakshi, where do you see the baseline heart rate here?
ma'am, in between the two contractions, ma'am.
Okay. Okay, so in between the two contractions, here two contractions, here two contractions. So here,
2 minutes should be there, ma'am. Big boxes.
So this is one place I can see. Okay,
Yes,
or
ma'am.
this is one place. Okay, it's good. So this is where. So and this is also another place. Okay, I have 2 minutes. So these are the places, and here also there is no contraction I can see. Do you call this as a variability? Yes.
Yes, ma'am.
Okay. Why I'm calling this as a variability? I will teach you. This is not an acceleration. When you come to the acceleration, I'll teach you. The acceleration, the dictum is like it is baseline. From the baseline, it will go up and come and settle in the baseline for some time. This is what the acceleration looks like. This is going up and down, up and down, up and down. It's not an acceleration. It's a part of increased variability. Okay. A period of increased variability followed by normal variability.
இது ரெக்கார்டட் வெர்ஷன் இருக்கும் யூடியூப்ல போடுவாங்க
Absolutely fine. Okay. Okay. So we'll go to the sinusoidal patterns. So this is a typical of sinusoidal patterns. Where do you find the sinusoidal pattern?
Ma'am, fetal anemia, severe hypoxia with acidosis, ma'am.
Fetal acidosis, hypoxia, as well as fetal anemia. So when you see this, what kind of anemia, the cause of fetal anemia, the causes of fetal anemia could be
Vasa previa.
vasa previa. Is intrapartum, you think about vasa previa, acidosis, hypoxia. Anemia
Rh negative isoimmunized.
isoimmunizations, then parvovirus infection. Okay. Parvo, if it is 32 weeks, not in labor, if you see this and a patient has some kind of viral infection recently, look for parvoviral infections. Okay, so this is smooth undulating pattern. How to differentiate this and the pseudo waveform? So there is something called pseudo sawtooth appearance from this to this. Okay, so what is the difference between these? This is more like a blunted thing. Okay, and even before or after this, the same blunted sign form will be coming. It never come to the normal. It may go into the flat line. Okay, but never come back to the normal. But sawtooth is a one. There is a sawtooth, some kind of kind of features will be there, and how to differentiate this from the sinusoid is this is preceded by normal, and it will, if you continue, this will come to the normal trace after some time. So when the sawtooth appearance can happen, when the baby's behavior is like when the baby is sucking, yawning, or doing some activities like sleeping, then this sawtooth appearance, most likely it's a baby sucking behaviors. This is again a good feature, so you don't have to worry about that. So this is called saltatory pattern. Saltatory pattern is like, you can able to see the saltatory pattern here. What is saltatory? Okay, if you see this and this, how many beats, it's going up and down. So if it is more than 25 beats, it's saltatory. Okay, it is actually up to the 25 beats. So I cannot say still at saltatory. Okay, it's up to the 25 beats. Saltatory is more like this, 25 beats. Okay, so though guideline says the saltatory patterns will stay like this for 25 beats for 10 minutes, even for 1 minute or 2 minutes, if you that, the hypoxia rates will be increases. So that is what they have found out. So this is more than 25 beats, like chuck, 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 it is goes up and down and stay like this for 2 to 3 minutes. 2 to 3 minutes means 3 big squares, 2 big squares. If it stays like this, and it is cannot able to come back to the normal, followed by decelerations or preceded by the decelerations, then that has to be very subacute hypoxia. Baby is having subacute hypoxia, profound hypoxia, the same thing. See, I said no, here if you see, this is called zigzag pattern. It's a minor version of the saltatory pattern. If you see the here it's 150, it's 120, almost it's like 100. So it goes up to that. 25, more than 25 beats is coming, going. Here also. So the beats are coming, going, coming, going, coming, going. This is called zigzag pattern. So this zigzag pattern is also again a part of hypoxia. So it's a hypoxia. Zigzag without repeated decelerations, then we can still wait. But with the repeated deceleration is a typical sign of meconium. It's a typical sign the baby has distress. So accelerations. Acceleration. This is the definition for accelerations. Okay. So typically acceleration is like it has to go up, you have to come down. It should not go up and
Deepa
come down
madam,
like this.
Deepa madam,
Yes.
there is one question. Please mark and show one big square. SR has messaged.
One big square.
Yeah.
Okay. This is, we can able to see it little better. Okay. So whenever you said you familiar with the CTGs. Okay. So always this is an x-axis. X-axis. Whenever you see x-axis means time. In even LCG, whatever it is go in an x-axis, is a labor car guideline is a time, and CTG it's a time. So time is like it's a one small square, and it's a two squares. Like this is called 1 minute. Like this is 1 centimeter and 1 minute. So the distance is 1 centimeter, the paper speeds, and 1 minute. So this is what 1 minute. So same here. So 1, 1. So one is a 30 seconds, another is a together. This is a
ஆமா
1
7
minute. Okay. The small square is only 30 seconds. So time is I have finished. Now I will go into the beats. Okay. When you tell the beats, you have to familiarize with the CTG paper. Here y-axis is the beats. Okay. This is like 60 beats, and then comes a 65 beats, and then comes a 70 beats, then comes a 75 beats. Okay, that means each square is a 5, each small is a 5 beats. So 5 plus 5 plus 5, then this is called the big square. So one big square I will mention here, from 100 beats, this one, and up to 110. Okay, this is one big square. Okay, so this is one big square. I'm putting it a half. So this is 30 seconds. This is 30 seconds. It's a 5 beats and 5 beats. Fine. Okay, clear? So whenever there is a reactivity happens, variability happens, it's in these squares, how many beats up, down. So one big square in this 10 minutes, if the up and down is maximum 3 cycles, the variability will be there. Okay, 3 times it goes up and down. So up and down will be the maximum 3 times. Computerized CTG will give us a more clue. So this is how the one big squares in this CTGs. There is some CTGs where you will be having lesser than this. So these are all the 5 beats. Some CTGs there will be only 10 beats variation will be there. So there you have to be having a more even the 10 beats variability which appear less, it is actually normal. Okay, so each small square will be the 10 beats in the y-axis. So there is some CTGs will be like this. I will show it whenever I get that paper. Okay. So these are all 5-beat CTG papers. We'll see one CTG's paper whether I have it or not. Exactly. This paper has 10 beats in small. So you have to familiar. See here is 60 beats, 70 beats, 80 beats, 90 beats. So here even this variability is very small because it's actually each square is a 10 beats. So in this 10 beats it couldn't even fully go up and down. It's only this is amount of itself is a 10 beats. Okay, fine. It's a very small square here. We will be putting it here. Even that if it is a small square, the beats, the variability is less here. Fine. Here 20 to big square means it's a 20 beats. So it depends, varies between the papers. You have to familiarize with the papers. That's why I'm telling some of the BPL machines, chronometric machines, you will be having different variability. So with this, that's a very basics. You have to familiarize with that. So now we'll move on to the acceleration. Acceleration, this is an acceleration going up and coming down and stable in the baseline. That is what accelerations. Acceleration in labor, if it is there, that's a very good somatic system is functioning, baby is moving. So all system is absolutely fine. If there is no acceleration, do not worry. Most of the times labor acceleration won't be there. But if you doubt, you would stimulate the baby by doing a vaginal examination. If there is an acceleration, then it's fine. Okay. Decelerations. Read the CTGs here, deceleration. Deceleration, same thing. It's like going down and coming up. All deceleration is the way the baby is getting an oxygenation by reducing the myocardial activities. But if there is a concern, then only we will be worried. What are the concerns? Whenever you see the deceleration, you have to assess the following things. First is time the decelerations. Okay, whether it is a early deceleration, variable deceleration, or late decelerations. Early is because of the head compression, variable is because of the cord compression, late is a uteroplacental insufficiency. Okay, so early and variable is normal in labor. Okay, variable deceleration with these concerning features. Say when there is a long, taking time for a long time to come into the baseline, or it's not coming to the baseline also, or it is a very broad deceleration, or there is no shouldering, or it's a reduced variability. Even in the baseline deceleration, there is no variability. These are the concerning features. If you have the concerning features in the variable deceleration, then even if it is persists for the 30 minutes, no repetition. Repetition means even repetition is every contraction if you have a variable deceleration. Variable deceleration without repetitions means even without contractions, if there is a concerning features, if it is last for 30 minutes, then it is amber. If it is repetitive variable deceleration with concerning features, more than 30 minutes, even persisting more than 30 minutes, it's a red alarm. Fine. Okay. Repeated late deceleration is equivalent to variable deceleration with all these concerning features. So even if you're not able to type the deceleration, I'm very confused with the late deceleration or variable deceleration. These two things, same things, variable deceleration with all these concerning features are typical late deceleration. So late decelerations, it's usually uniform. Uniform means every contraction it will be there. And it will mimic, it will be repetitive and it will be there uniformly. Variable, it's not uniform. Sometime it will be there, sometime it will be shallow, sometime it will be more complicated. So that is why difference between the late and the variable decelerations. I'll show it to you. What is this deceleration? What is this deceleration? I'm putting the deceleration, I'm seeing this. So why you are calling this as a prolonged deceleration?
Because it lasts for more than 3 minutes.
Okay, what is this? Is a
Delayed
big
recovery.
it's not even recovery also, but duration is like from the start to the end. Okay, so end is still not come. Okay, it's recovering and staying in low baseline only. Okay, that is one thing. So when do you alert the team? When it is a two big squares, that is 2 minutes. This is a 2 minutes. Fine. So when you have to alert the whole team when there is a deceleration, when the deceleration lasts up to this, you have to alert the team. At 3 minutes, you have to start the resuscitation. By this time, you will be starting all your resuscitation. What are the resuscitation? Stop the contraction first of all. Okay, put the patient, change the position of the patient if the patient is supine. Stop the contractions. How do you stop the contraction?
Stop symptom.
If there is no symptom.
Terbutaline.
Tocolytics, terbutaline. So stop the symptoms. And second thing is like this is baby is contracting more. There is a intrauterine pressure is more, which is not able to make the uteroplacental flow. So what do you do?
Left lateral position.
Left lateral position, reduce the decompression. Second thing, if the mother is hypotensive, start
IV
IV.
fluids.
Even
Okay.
an active.
IV fluid. Now most of our Indian populations, better to start a hydration. They will be dehydrated. So better to start the hydrations. So by this 3rd minute, you will be starting all your activities. Okay. All your, so if suppose if it is a previous LSES or if there is a bleeding or if it is a cord prolapse, then you won't be.
Uterine rupture.
That are irreversible. We can't, even if you resuscitate, those are the things we cannot correct it. Fine. Last class I got told in the hypoxia class, if you have 3 irreversible things like cord prolapse, the cord is outside. So whatever the resuscitation you do, it won't correct. So you have to deliver the baby faster. Abruption. There is a retroplacental clots. It's an ongoing effect. Will it correct by giving IV fluid and waiting and resuscitating? No. You have to deliver the baby. And uterus rupture, scar ruptures. If the baby is alive, as soon as possible, shifted as a category 1 cesarean section, you will be doing it. Okay. If you ruled out all those things in the 3 minutes and do resuscitation, then probably it will recur. Continue the CTGs. Okay. So this is what prolonged. So once you categorize the CTGs, this always I'll tell everyone, this is the way you have to look for the cause. Whenever you have a problems, use the mother's mnemonic. Okay. Whenever the CTG gives a clues or you categorize this as a pathological, you rule out meconium, you rule out oxytocin is the reason. Is there maternal temperature? The uterus is very hot or not? Is there any hyperstimulation? Is there any bleeding TV? Is she on epidural? What is the rate of progress and scar? So this is mother's mnemonic. Okay, you remember this. Whenever you have the resuscitation protocol before you start, you have to correct all those things. If it is a correctable, the scar can't be correctable. The hemorrhage can't be correctable. Okay, the things can be correctable. Fine. Okay. So spoiled is a mnemonic. You have to do treatment, management. Stop oxytocin, position oxygen only before anesthesia or in a case of maternal hypoxia. If the maternal saturation is less than 95%, giving oxygen will help the baby's bradycardia, otherwise won't. IV fluid balance, if there is too low BP, like after epidural, probably ephedrine vasopressors will help you and tocolysis. With this tocolysis, we expect the recovery of the fetal heart in 1 to 2 minutes. Okay. So now it's Anita's time. Anita, this is your case. Can you read the case and categorize the CTG? Anita, are you there? If Anita is not there, Akshi, can you able to do it? Anita Parthasarathi? Apurva? Where are these people? Sorry, anyone can review the CTGs?
Ma'am, yes, ma'am.
Apurva.
Ma'am, first, according to Dr. Sri Bravado, will classify the CTG. So first is DR, that is defined risk. So she has no risk factor.
Okay, she's
Uh,
39
then,
8 weeks primary, spontaneous labor, no risk factors. Good. Okay.
then we'll see the contractions in 10 minutes.
Mm.
So if we see the contractions, she's having almost 3 to 4 contractions in 10 minutes, ma'am.
Okay. Okay. So when you see the contractions, okay.
10
So
minutes.
what are the contractions? There are 3 things I told you to see it. What are those things?
We have to see in 10 minutes how many rest period should be there. So rest period should be there for 90 minutes, 90
90
seconds.
seconds. That means more than 1.5. Are you able to see the rest period here or here?
Rest period is there, ma'am.
Where?
2 squares are there.
No. Here,
Yes.
okay. So we need rest period at least. I said this is
Mm.
30 seconds. Okay,
Okay.
1 minute. Okay, this is end. It's like a 90 seconds. Okay, 90 seconds. Okay, at least 2 minutes we needed it. At least 90 seconds is fine. But where do you see here? It's only a 30 seconds.
Not there here. Yes, ma'am.
Only not that. So even there is no rest period and the contraction is keeping coming. And the tonus here, how many minutes it take? More than 2 minutes.
2 minutes up to the hypertonus. It is
More than 2 minutes. Okay.
2 minutes are there.
So
Okay, ma'am.
now define the contraction.
So contractions, she's having a hyper tonic contraction with reduced rest period.
Very good. Now read the CTG.
Ma'am, so defined as she is having no risk factor. Contractions, she is having hypertonic contractions with reduced rest period. Baseline heart rate is 140 beats per minute. And then the variability is around is having normal variability around 8 to 10 variability is there, ma'am. And accelerations are also present.
Very
There are
good.
no decelerations.
Okay. Where do you put this lady? Is Dr. C. Bravado? It's normal or not?
Normal CTG, ma'am.
Why? I
No,
said
not but hypertonus contractions are said there. So
even there is
there's
no
amber ಇದ್ಲದು.
number. Okay. Even there is no CTG abnormality. The baby's heartbeat is fine. Everything is other parameters fine. My contraction pattern, she is getting hypercontractions. So even though she's 6 centimeter diameters bag of membrane with adequate contraction, we will watch over it. Okay. Suppose if it is decelerating, you will be ready with the other things. No ARM, no oxytocin. Agree?
Yes, ma'am.
Okay, so that is after getting more contractions, he should not go baby could not go for the deceleration afterwards. Okay, so
Yes,
this
ma'am.
so I have mentioned is normal. It's not actually normal. Fine. Okay, overall, because of the contraction, we will watch. Apurva, this is the CTG for you.
Ma'am, first define risk. She is a known case of GDM on MNT. Then we'll have the contractions. We'll see contractions. If we see she's having
See, she has a GDM membrane absent. Those two risk primary GDM membrane absent. Two risk factors are there. Correct.
yes, ma'am.
Okay, when you read the CTGs, there are two risk factors. You cannot go with only with the history. In obstetrics, in the intrapartum period, the risk assessment has to be done every 1 hour because it is a dynamic. So quickly the changes can happen in obstetrics. So that is the reason we are doing a CTG assessment even on continuous. Every 1 hour we are assessing the lady. Okay.
Okay, ma'am.
So contractions.
Contractions. She is having 2 to 3 contractions, ma'am. Rest period is there, not hypertonic.
Very good.
And then baseline heart rate will be seeing in between the contractions. So it is around 130.
Okay. Very
And
good.
then
In between the contraction, in between the two deceleration, you will be seeing the baseline heart rate. Variability?
variability is also normal, ma'am. Variability is around 7 on the மாதிரி இருக்கு, ma'am.
India?
Th-
Are you happy? These two variability?
This is increased variability.
This is normal. This is little less variability. Okay. Are you happy?
No, ma'am.
Why you are not happy? I told
Increased
in a
variability.
in a CTG, if there is a sleep pattern is seen, okay, that's fine. The baby is absolutely doing very well, right?
Okay, ma'am.
But we'll continue the CTG because of the deceleration. Are you worried about this deceleration? What type of deceleration? Whenever there is a deceleration, I told you, you have to type the deceleration
It is along with the contraction only.
along with the contractions. Then What is this? Is
Early deceleration, take
what
it
is,
them.
what is
Early
this?
deceleration,
Why early decelerations?
because corresponding with the contractions. But
Okay.
variable deceleration,
Contraction, every contraction, early and late is you should be uniform. So when you see early or every contraction, it has to be there. That is called early decelerations, and it has to be uniformly seen. Okay, here it is not uniformly seen. Okay,
yes, ma'am.
so it is not a. There is one clue here. Okay, the baby's heartbeat is going up and then decelerating. What is this called?
Shouldering.
That is called shouldering. So this is called shouldering, and this decelerations is goes down and come up very quickly. Okay. Cardiac deceleration. Can I ask everyone, please mute yourself? Other than the speaker, please others mute yourself. Okay. Okay. So that is why this is a variable deceleration.
Variable deceleration.
Okay. Then whenever you would say variable deceleration, you have to look for concerning features.
Concerning features.
Okay. Is there any concerning features?
No, ma'am. Shouldering is a good feature, and it is recovering back early. Like not prolonged recovery is not there, so concerning features are not there.
Very good. So you call this as a, right now you call this as a,
Normal only.
okay. See, 7 centimeters membrane absent and GDM on a meal plan. Will you stop the CTG or will continue the CTG?
Continue the CTG, ma'am.
Okay, good. So because he is having a GDM, high risk pregnancy, so we'll be continuing the CTG. Okay. So this is out. You call this is a baseline and this is normal CTG. Sakshi, are you there?
Yes, ma'am.
Yeah, read the CTG, Sakshi.
Yes, ma'am. G2A1, ma'am, 38 weeks spontaneous labor, ma'am, no risk factor. And head is 3/5 palpable. Cervix is 4 centimeter, well, effaced and 4 centimeter dilated. Bag of membrane present and -2 station, ma'am. And this is a last hour CTG, ma'am. Here in this CTG, ma'am, according to Dr. C. Bravo, the defined risk is no risk, ma'am. So, and contractions are there, ma'am. 3 contractions are there, ma'am, in 10 minutes. Then baseline variable baseline FHR is around 140 to 145, ma'am.
I
And
told you, can I interrupt? Whenever you mentioning the baseline rate, I want one number. I don't want
yes,
a range.
then
Okay, tell me the
140,
one
ma'am.
number. Huh?
140, ma'am. 140,
140.
ma'am.
Okay, good. 140.
Yes, ma'am. And variability is decreased, ma'am. Here in 2 contractions, no less than 5 variability are there, ma'am. Maximum it is 3 variability is there, ma'am.
So less
And
than 5 beats. Okay.
yes, ma'am. Accelerations are not there, ma'am. And
Okay.
decelerations are present, ma'am. Here is a, deceleration, ma'am, which is with the contraction only. But we can't tell her that deceleration as a early deceleration because it is not a pattern, ma'am.
Okay, good.
So because of that, we'll tell it as a variable deceleration, ma'am.
Okay.
So we'll continue the CTG, ma'am, and then we will resuscitate the patient, and we will see for next method, ma'am.
Okay. So you categorize whether it's a suspicious or pathological?
Ma'am, it is a suspicious, ma'am.
So suspicious means we'll do the resuscitative and continue. Suppose if
Yes,
the
ma'am.
same pattern persists for another 1 hour, another 50 for 30 minutes, already it's 1 hour, another 30
Yes,
minutes.
ma'am. Then we'll try it as a that instrumental delivery or LSCS, ma'am.
Okay, depending upon the progress of the labor.
Progress of the labor, ma'am.
Okay, done. Good. So this is for Anita. Is Anita is here?
Yes, ma'am.
Tell Anita.
Ma'am, it's a case of gravida to paragon 11, 38 weeks, spontaneous labor with no risk factor. Per abdomen, head is 1/5 palpable and cervix well effaced, 6 centimeter dilated with spontaneous rupture of membrane, clear liquor, vertex at -1 station.
Okay.
Uh, Ma'am, to define the risk factor, there is no risk factor. And contraction, it is three contraction, ma'am. It is three contraction with the baseline. Maintaining. Baseline is at 120, ma'am.
Okay. Baseline, where do you read 120 here, Anita?
Ma'am, that's yes,
This
ma'am.
okay. So this is the baseline because it's a calm when there is no two contractions, you in between two acceleration, you are reading it. Okay, so it's
Yes, ma'am.
120. Okay. So this is the baseline heart rate. So in and around the baseline, if anything is up and down in a one big box, it's a variability, correct? It goes
Yes, ma'am.
beyond that is a accelerations. It's an increased variability. Acceleration means it goes up and come down and
Comes to
so this is acceleration. This is a small acceleration coming down. Okay.
yes, ma'am.
So 120.
Ma'am,
Mm,
yes, ma'am. And about variability, it is um 10 beats, 10 beats variability is there, ma'am.
okay.
Accelerations is present.
Mm.
There is no decelerations, ma'am.
So what do you do?
Ma'am, this is a overall impression is it is a normal CTG.
Mm.
Since she is 6 centimeter dilated, I'll will continue the monitoring,
Yeah.
FHR monitoring.
Will you start oxytocin?
Uh, 3 good contraction is there, ma'am. So no need of
You don't need. Okay.
yes, ma'am. Yes,
Okay.
ma'am.
Good. Very good. Okay. So this is fourth CTG. Fifth CTG is for Apurva again. Sorry. Apurva.
Yes, ma'am.
Okay. Just read the CTG.
Ma'am, she is a case of primary gravida, 40 weeks, and induction of labor was done with Serviprime gel, no risk factors. On examination, head is 3/5 palpable, and per vaginal examination, cervix well effaced, 3 centimeter dilated, bag of membranes present, vertex at -2 station. Ma'am, if we classify the CTG define risk, she is having no risk factor. And then contractions
How
in the
come
whole
you say it's a no risk factors?
uh,
Induction of
40 weeks.
labor. Induction of
Any induced patient has risk factors. Oh, yes, ma'am. Yes, ma'am.
Mm-hmm.
So she's an induced patient. Then contractions in the whole CTG of 30 minutes, there is one contraction. She's not having regular contractions. And then baseline baseline rate is around 160,
Okay.
160 beats per minute,
It's
which
white
is
or
not
amber?
normal for 40 weeks.
Good girl. Okay, it's a amber then. Okay, then.
Then there are no accelerations, ma'am. There is a prolonged deceleration. It is taking time to recover to baseline. So this is a pathological CTG.
Very good. Okay, so there is prolonged deceleration as well as a tachycardia. Variability is, we have to see the variability in the decelerating arm, which is not there. So though there is a recovery, its recovery is going in for high, like more than 160, it's reaching and staying. So it's a compensatory hypoxia. So if the patient is not going to deliver even after resuscitations, we have to take immediately for the cesarean section. Okay, so pathological CTG. So one last last one for Sakshi. This is the last for the CTG for the day.
Yes, ma'am. Ma'am, primary, ma'am, 38 weeks with spontaneous labor, no risk factor. On examination, head is 1/5 stable.
Deepa ma'am, sorry, now is 7:10. Just informing.
1 second. This is the last one, ma'am. Okay.
Cervix well effaced, 8 centimeter dilated, ma'am. Membranes absent and vertex at -1 station. Clear like a draining. This is the CTG for last 50 minutes, ma'am. According to Dr. C. Bravido, ma'am, no defined risk is there. Contractions are 3, ma'am. And baseline FHR is 150, ma'am. And variability is less than 5, ma'am. That I can say 1 or 2, ma'am. And accelerations are not present, ma'am. And decelerations are variable, ma'am. According to contractions, decelerations are variable.
Okay. Where baseline heart rate?
Ma'am, baseline heart rate is 150, ma'am.
What others you will be seeing in the baseline heart rate? One is appropriate for gestational age. The other thing is,
According to
no, there are three things when you see the baseline heart rate. One is number one, we have to write the number. What exactly? One number you have to write. What is the baseline heart rate? Second, it's
Yes.
an appropriate for gestational age. And third one is rise
third
in
one,
heart rate. Rise in heart rate. The previous
according to
question is-
previous
Okay.
CTG,
One
ma'am.
more thing. One more thing I have told in my discussion.
Stable.
Very good.
Yes, ma'am.
Whereas is it stable?
No, ma'am.
Why it's no? It's okay. No, it's stable, right? Whenever you have doubt, you just knock out all the
No.
CTG trace and see it's stable. No, one line it is coming, right?
Yes, yes, ma'am.
Okay, so these are the things where 160 it is coming exactly in one line. Okay, and each line is coming up 2 squares. So almost 2 minutes. Here only 1 square, but here it's almost 2 minutes. Here also almost one. So it is stable, right?
Yes, ma'am.
Okay, fine. Okay, go on. So baseline heart rate is 160 tachycardia with stable. And there
Yes,
is
ma'am.
variable decelerations with the complication and without complicated features.
Ma'am, without complications. No, ma'am. Complication is there, ma'am. Membranes are absent, ma'am.
No. The deceleration. When you say that it's a deceleration, you have to type the deceleration, which is variable.
Yes, ma'am.
Now
Variable.
you have to say it is there any concerning features or there or not?
Cord compression.
Concerning feature I meant it's like the deceleration for how how long it will take its time to come to the recovery. Okay, is there any prolonged W shaped or is there variability in the CTG? Is the variability inside the decelerations? What I'm asking is there any variability? Because there is lots of no less variability in each deceleration arm. Okay. And
Yes, ma'am.
it's almost like a tachycardia. So all these features is a complicated CTGs. Okay. So this is already for 50 minutes. Okay. So you do a resuscitative measures, make it correctable. If it is not correctable, reassess whether she is progressing into full dilatation
Full
sum.
dilated.
And if not, deliver her. If not, deliver her by C-section. Okay.
Yes, ma'am.
IME 8 centimeters with pathological CTGs staying more than 30 minutes, 50 minutes, it's not very a good sign. Okay.
Yes, ma'am.
Sure, sir. So with this, I'll close this sessions. I thank Apurva, Anita, and as well as Shakshi for their excellent interpretation of traces. I have not covered the hypoxia topic. We'll cover it in the next session, next month. Okay.
Thank you, Deepa ma'am. It was an excellent session. More than 1 hour, 15 minutes, you have been talking alone, including the girls, Apurva, Anita, and Sakshi. I think those who have joined will really benefit from the session. And I could hear voices saying we can learn from the YouTube recording. So, who have not joined would have benefited through the recording as well. It was an excellent session. Really like to congratulate you as you have taken the whole session, single person for 1 hour, 15 minutes. Thank you. Thank you so much, Deepa ma'am. And thank you
Sorry, Meena,
all the girls.
we just overshoot the timing this time. Okay.
No, why I am concerned is because we have another session at 7:30. That's
Okay.
all, madam.
I just need a photography because you were asking for art activities. So I want everyone, Sakshi, everyone just for video, open your videos, man. Sakshi, Anita, Apurva, please open the videos. Gallery. So I'll take one. Yes. Thank you.
Dana madam is there. Dana madam can open the video and
Dana, madam. Yes, ma'am. Thank you, ma'am.
Dana madam. Yeah. So we have our vice president ma'am and others who were possible. Please open the video. Meenalochini madam. Yes, madam. We can take
Thank
a
you. Thank you. Thank you.
photo.
I have taken
Thank
the
you
necessary
so
photo.
much, madam.
Thank you so much. Bye.
Thank you, Dana ma'am, for
Thank you, ma'am.
providing. Thank you, Anita, Purva, and Sakshi